Good afternoon, everyone, and welcome to our section, Revolutionizing the Health Workforce AI-Driven Strategy for Upskilling and Equitable Access. My name is Papatung Rasami Virya, a fifth-year medical student at the Faculties of Medicine, Siriraj Hospital, Mahidol University. We are delighted to have you with us to explain how digital health technologies and artificial intelligence can transform healthcare worldwide and empowering the health workforce at all levels to deliver high qualities and also patient-centered care. So since the morning, we have explored how integrating technology with healthcare strengthening system, advance the sustainable development goals, and also fosters a healthier planet and enhancing diagnose, personalizing cares, and tackling resource-limited challenge. So next, we will examine how cutting-edge tools and data-driven insight and digital platform are shaping global health from clinical decision-making to broaden the public health initiatives. So ladies and gentlemen, today's section is a deep dive into the transformative powers of digital health technologies, exploring how they enhance patient care and drive professional developments. Throughout these sections, we will hear comparing stories and also the experience from our panelists as they will share strategy for training healthcare professionals and scaling innovations across all levels. With AI-powered platforms at the forefront, we will uncover how these technologies can ensure equitable access and also alleviate the standard of care. But that's not all. We also explore how large language model and AI-driven tools empower individuals with personalized health information, encouraging self-care, preventive health, and better decision-making. By highlighting AI-based tutoring, mentorships, and personalized health assistance, we will highlight how these advancements democratize healthcare knowledge and foster continuous professional growth. So policymakers, educators, healthcare workers, and technology developers are coming together to shape a future where digital technologies advance high quality, ethical, and equitable care for all. So at this point, I'm honored to pass the microphone to Dr. Hong Wang, who will serve as our moderators and introduce our speakers. Dr. Wang is a senior policy advisor in health economics, financing, and system strengthening at the Bill Melinda Gates Foundations in the United States. With over 3 decades of experience in health economics and financing across various low and middle income countries, he managed key healthcare financing initiatives in the Foundation Beijing office and beyond. Dr. Wang is also an affiliate professor in the Department of Global Health at the Universities of Washington. Dr. Wang, now the floor is yours.
Ladies and gentlemen, good afternoon. Very honored to be a moderator of this session. We have a very distinguished panel this afternoon. So I think giving our 2 hours time, with the first part we will asking the 6 speakers to give a presentation talking about the framework of digital health and AI in health system strengthening, and also talk about the development of AI and digital tools to support the health workers to improve their work. And also we talk about the examples from low middle income country about the implementation of these tools underground. And lastly, we will have some presentation regarding how to improve their skill and capability to use this technology in practice. So, and after these presentations, we will have an open floor for Q&A and a panel discussion. So the first speaker will be Dr. Kate Tolanko from Covo Health. She is a CEO of the Covo Health, and given the time, short time, I won't go to detail about the CV of her. You can look at her bio online. So the floor is yours, please. She will talk about digital health and AI from a concept framework perspective. Well, there's a
timer. Oh,
well,
wonderful.
there's a time.
Fantastic.
There's a time.
Okay, great. So good afternoon. I'm Dr. Kate Talenko. I'm the CEO of Corvus Health, which is a global health workforce firm. I previously served as the head of the USAID's Global Health Workforce Project and as the coordinator of the World Bank's Africa Health Workforce Program. Let's see. So bottom line is health workers are afraid. They're very frightened of the concept of AI and that their jobs might be taken away from them. So I want you to keep this in mind as we talk for these 2 hours about the introduction of AI into healthcare and the role of health workers in this. Just looking at some of the data, health workers are afraid they'll be replaced, that their jobs will go away. In fact, I've had tech bros come up to me and say, I'm going to put you out of business, I'm going to put you out of a job. That's not very helpful. Creativity, innovation does not foster in a climate of fear. We all need to support one another. Here you see 75% of employees are concerned they'll lose their job. And it doesn't necessarily get better the more people experience AI. In fact, it gets worse. The more people interact with AI, see how powerful it is, the more fearful they get. So as health system and hospital leaders, we all need to work on this, help allay people's fear, help make sure they understand the role of AI in the system and the role of AI in assisting them. And also, physicians are worried about the change in the doctor-patient relationship. We know that the rollout of EMRs, particularly in the West and the US, greatly worsened the doctor-patient relationship. Patients say the physician spends more time staring at the computer than staring at me, or I never get to talk to the physician anymore. Physicians and other health workers are concerned about the ethical and the legal issues of AI. AI might give me advice, but it's my medical license. What is AI going to tell patients to do that might not be the right thing to do. And also many health workers have concerns about their professional identity and autonomy, that the workplace will become even more sort of cold and clinical, pun intended. I remember when in Washington, D.C., a restaurant called Itza opened, which was a restaurant that had no visible staff. And I went because I was very curious, but it was a very alienating environment. I was the only customer in the restaurant. I couldn't see a person. My food popped out of a door. Needless to say, these restaurants all closed down. If there's any industry where people want a smile, where people want a warm hand, it's healthcare and also elder care. So we know that jobs are going to be lost, but that the healthcare industry is a human industry, and that we have to consider this when we do our change management. And so in my presentation, I'm going to talk about 2 frameworks. One is for the AI change management, and the second is digital integration within health systems. And people often ask me, well, why do you present frameworks? You do a lot of research, you do a lot of implementation. Why don't you talk about those specifically? Well, if I spoke about how we're integrating AI-assisted breast ultrasound into the clinics in Côte d'Ivoire, which we're doing right now, you learn about what we're doing in Côte d'Ivoire. But if I teach you a framework, you can then repeat it and use it in your context, which might be very different as far as the population, the diseases, the actual stage of the health system that you're working in. And also, I teach frameworks because there's a real shortage of health worker expertise. When you look at the 6 building blocks of health systems, almost every school of public health has certificates or entire courses on the other building blocks: leadership, IT, delivery systems. But most don't have any programs in health workforce. In fact, outside of South Africa, I think in Africa there's not a single certificate degree program in health workforce. So it's a huge challenge. And also, health workforce is very complicated. Labor markets are extremely complicated, and we'll go through the framework for that later on. So in the change management steps, it's important to involve all types of health workers up front, that everyone, even if they're not on the change management committee, that they have a chance to give their input, that their concerns and fears are listened to. You have to really make it clear that the adoption is not about cost savings. It's about improving patient outcomes. It's about assisting health workers to make their work easier. It's about AI assisting humans, not the other way around. And you have to, create a team that includes all types of health workers. Often it's just physicians and nurses, and other types of workers such as lab techs, community health workers, pharmacists, dentists are left out. So you have to make sure it covers the whole of your system. And also make sure that you're clear that if people do get made redundant because their work goes away due to AI, that you will work as much as possible to absorb them into the system. For example, in American hospitals, the average staff turnover rate is 20%. So you lose 20% a year just normally. So, with 20% loss on a natural year, if you need to make 10% redundant, you should be able to absorb them into the system without a problem. And you need to really communicate in meaningful ways, not just email blasts, but sessions, sitting down, talking to people, hearing about their fears, allaying their fears. And you need to work with the health workers to identify where in the workflow they feel AI would be most beneficial, what right now is most problematic to them, what takes the most time that they feel it shouldn't. Is it taking the patient's history? Is it some of the data analysis? What is it, and what type of AI products would be helpful for them? And that's where the IT team comes in to identify some of these products, test them to see if it integrates into the system. And then if a AI application is chosen, health workers throughout the next slide. Before I go to the next one, we have identified at least 50 AI use cases in the health system, and this is just about half of them. And as you see, AI really can be used in any patient pathway in the workflow of any type of health worker. And if you come away with just a few thoughts about my talk, I want you to think, of course, about health workers being humans and valuing them and allaying their fears, but also about workflows, and that anything you introduce needs to fit into their workflow, make it easier. You might have to redesign the workflow completely, but you can't just put something in the middle of it and expect things to work the same. Okay, so back onto the change management framework. So you want health workers in different settings to test this AI system that you're looking at scaling up. Does it help them? Is it intuitive? Does it give good results? Does it increase the health worker-patient relationship rather than form a divide in between the health worker and the patient? And then, based on that feedback, you decide whether you accept that software or, reject it and look for something else. And then comes time for training. And we find that most training is just an afterthought. It may be half an hour, maybe on a weekend or an evening. I have been trained on about 5 different electronic medical records as a physician. I have never been paid for that training. So it shows that the hospitals do not value my time. They do not value the training because they're not even willing to pay for it. And also the training needs to be evidence-based. That means that it needs to be designed by people who understand your pedagogy, understand learning theory, understand also how the software works. So it usually needs to be designed by a team of health workers, IT people, and then curriculum designers. And then there needs to be follow-up on the training. And when you implement, there needs to be 24/7 support, because remember, these are healthcare systems. They never sleep. The ER is always open. The hospital is always open. Urgent care is always open. And you need to identify and train, champions and experts who, as I thought was very well presented in the main plenary about how people need to bridge the divide between the healthcare understanding and the IT understanding. Okay, and of course, for any process, you need to measure the success of your integration. So on the left, I have the traditional measures, the revenues, patient volume, quality of care, patient outcomes. You do need to continue to do that. But the second is really what's going to be most important with your health workers. Are the patients satisfied? Has it improved their experience? Are they more compliant with their treatments because of what you're doing? Do they sort of own that more and more likely to take their medication, to do their treatment? Has the health worker job satisfaction increased, and has your health worker retention increased? Because you want to see all these increase or at the least stay the same. And so I went backwards. Oops, okay, hold on. Okay, this is the health worker life cycle. There are 10 elements. This was originally developed by the World Bank and the World Health Organization to simplify sort of the complexity of labor markets. And it's everything from data, policy, regulation, financing, unions and professional associations, 4 types of education, recruitment of health workers and distribution, health worker management, which is classic HR, burnout, retention, and then manage migration. So if you integrate technology into all of these aspects, this is sort of the roadmap to how to do digital integration of your health system from a health workforce point of view. You'd also probably want to map it on the 6 health system building blocks as well to make sure that you're not forgetting anything in your health system. And so here we see the first 5 domains there in the left column. On the right is the type of tools that you would want to integrate to make these domains, these elements, work better. So we have the National Health Workforce Accounts, the M&E software, the WISN, which is a way of looking at staffing workload, for policy and regulation, and that also includes communication. You're going to have your customer management software because you need to make sure that you're talking with the nursing group, the physicians group, the dentist. You need to make sure that you're talking with the health professional schools. It's like I'm out of time, but my presentation will be available. And you see for the other 5 ones, similarly, the type of digitization that's done in these domains and the type of software that can be used. Thank you.
Thank you for Dr. Kate Tolank's presentation, and she brought up the framework of AI use in terms of management of health workers, related to the management tools, training tools, as well as measurement and performance tools. And also she raised a very, very critical issue, which is about the concern of health workers of utilize AI. It's not just in Africa, but also in other parts of the world as well. So given the time constraint, we were not asking people to raise questions at the moment. We will probably reserve all of these towards the end of the presentation. So our next speaker is Dr. Alex N from Tencent Healthcare. He is president of Tencent Healthcare, and he will introduce how Tencent developed digital health tools to support the improvement of healthcare.
Thanks, Hong. So the title of my speech today is going to be about how we use technology to empower the healthcare journey. But let me start off by saying what we are trying to do is we're trying to solve a 1.4 billion problem in China. There's roughly a bit more men than women in China, but the demand for healthcare that we're facing is maybe not so dissimilar, even though China right now is already an upper middle income country. Health literacy is improving, but it's still relatively low, rank 29%. Even though it's still a developing country, we have a very developed disease burden, where if you look at the disease burden in China is very much largely chronic disease rather than infectious disease or road injuries. But I think more importantly, we are now in some ways suffering from the legacy of the one-child policy, whereby if you look at it, this is a very, very typical family structure. But then a lot of that responsibility of the healthcare falls onto this mother over here, where she will have to coordinate the healthcare for the kid, for the husband, and also for the four sort of parents and parents-in-law. Now, in China, we have 4 million doctors. That's quite a lot. But if you look at it from a ratio perspective, it's not that much, right? But then if you compare, it's very similar to Canada. Canada is also a geographically very, very large country, very similar to China. But the difference is actually not just on the top level of numbers that you look at. It's also the educational level. All doctors in China are not being educated equally. There's a lot of doctors, what we call village doctors, who will only have a high school diploma. And some will have maybe a bachelor's degree, and only about 17% will have a master's degree or above, right? The so-called sort of the Western definition of a postgraduate trained doctor. Now, if you then divide this number by 0.17, times it by 1.7, it's actually not a lot, right? And as a result of this discrepancy, I don't think a lot of doctors in China are fearing AI because by looking at the ratio, there are just not enough doctors to go around. But what happens is that this imbalance between supply and demand, and all those 70% of the master level or above educated doctor are concentrated in major cities, in large hospitals, in tertiary centers. And what happens is you see this huge internal domestic migration of the unwanted medical tourism within China to look for the right doctor. Now, I think this is even more rampant because China doesn't have it's still only building its primary care system. So there isn't a gatekeeper or referral system. So people tend to refer themselves to whichever specialist they want. Now, to solve this problem, this is a huge problem, right? Tencent, we're only a small tech company, like trying to do our bit to help. But then to solve this, I'm very lucky because to solve this, you will need a ubiquitous platform, right? I think in today's plenary, people say, well, this is about platform technology. And I think China is very good at platform technology. And at Tencent, the good thing that we have is that we have WeChat. Now, WeChat is in the business, is only 14 years old. We're in the business of connecting people, enterprises, services, and content. It basically is similar to Line that you use here or WhatsApp, right? You chat with people. But as it evolved over the last 14 years, it's evolved into something different, right? Moving on from just chatting, well, you can now share, just like you would share on Facebook or Instagram. We will actually host corporate accounts and websites and video accounts similar to TikTok, right? If PMAC has a website, right, you can technically have a official account of PMAC in WeChat. But then we exploded and expanded into payments. And I think what makes us so powerful that some people call WeChat a super app or the original super app is because of mini programs. Mini program is a very, very easy to use sort of application, still owned by Starbucks, still owned by the store owner, right? But then they can use the WeChat platform to do business, to communicate, to share. And of course, you've got other functions, right? So WeChat, it started off as an instant messaging tool, and now it's blown up to be a very, very large platform. But so how can we use this platform for healthcare? And the way I look at this is, I think very similar to what Karen was saying. Like I look at it from a journey perspective. So there are things that a patient can do at home This is the green part, right? But then there are other aspects that because healthcare is in nature, you can't take a pill on the cloud. You can't take a surgery wearing a VR goggle, right? You still need to go and see a human doctor, whether you like it or not, in the next 10, 20, 30 years. So then how can we use this AI or digital technology to enable the offline experience? And then at the end, the patient is going to leave the hospital, leave the clinic somehow. Once they go home, what self-help tool can they use? So this is what the majority of my talk is going about. It's going to walk you through a little bit of the journey of how we use technology and how we use AI to empower not only just the doctors in the hospital, but also patients at home. Because if you alleviate some of the burden that the doctor is facing, they are going to be much better doctor because they don't have to answer the same questions, which they don't have the time for. Now, so what we do, I mean, not all of you have WeChat. If you have WeChat, you can use WeChat to scan this code and you'll be able to see what you have. The first thing that we do as well to solve the medical literacy problem, to combat disinformation, the first thing we did, we built our own medical content platform, where first we license and work with WebMD in the US, HealthEyes in the US. We license the content, we translate to the Chinese, make it available to our WeChat user. But from then on, our editorial team continue to produce articles and animations and videos about the contemporary healthcare topics. And all of our articles and videos are peer-reviewed by a consultant-level doctors in a large hospital, so that to make sure that this is actually legitimate and is appropriate. And then how do we aggregate all the service to make it available to all our users? We aggregate it into one platform. Right now, we have over 800 million users, and each month we have more than close to now 100 million users using our platform to find the doctors, to pay for the healthcare online, using their IDs and payment tools. And more importantly, the content that we have, if you subscribe to the disease that you like, we will be able to notify and push you relevant medical content that is tailored to your need. And then once you're at the hospital, as I mentioned, that there isn't a primary care. So what you do is you triage yourself. What we did is we built a very simple triaging chatbot. You can use it on the phone, or you can use it at the hospital in a big computer pane, where it will direct the patient to the right specialty, so they don't actually make the wrong appointment. This so far is being used by more than 1,000 hospitals, and we're probably adding 1 or 2 hospitals a day onto our platform, so that they can actually make better use of the AI to triage the patient, so that we basically reducing the lines lining up at the hospital. And then one thing that we're also trying to tackle with a ubiquitous platform is Common ID. Common ID is very, very hard to come by in China. Each hospital has their own ID system. We are working with the government to make one electronic ID for all, so that the patient can use the same ID across different hospitals. Now, that doesn't mean that the information within the hospitals are interoperable or interconnected, but at least they have the right same key to be able to access the hospital data, rather than which often we will see a mother will be carrying a booklet of different cards. These are different ID cards of different family members that they would need to go to the hospital setting. Now, because of the doctor-patient imbalance, you only get about 2 minutes per consultation in China. So what we did is we built a chatbot. The chatbot doesn't answer your question. This chatbot asks you questions, just like how a doctor will ask you a question on a pre-consultation. So we take your complaint, we take your history, we take your allergy, all of your information. A doctor would normally spend 10 minutes asking you if you're a new patient. So what we did is we did all of this, and we were able to summarize it, not just verbatim. You can actually speak to it. You can also upload your test record, and we will medically OCR it into a structured format and then push it to the EMR, so that using the time sitting in the waiting room, you will have very structured information for the doctor. So as soon as they see the patient, they will be able to have a quick understanding of what's wrong and make the best use of the 2 to 3 minutes that they have with each patient. Now, this is the AI. I won't talk too much. I think all of you guys have seen it around. I think this is, to me, one of the least talked about, but I think one of the most important educational tool within China. Now, these tools, if you put in the best academic university hospital, we'll say that these AI are not inferior to the consultants over there. But I think these two ultimately will have the biggest benefit is actually in the rural hospitals, where they can actually be a very, very important quality checker for the doctors, so that when they're unsure about a polyp, unsure about the colposcopy, unsure about the diagnosis, they can use these AI. And we have done clinical trials. We've been registered with the NMPA, which is the FDA equivalent in China, so that we know that the standard of which these AI perform is similar to a high-level doctor, so that the rural doctors can be assured that like they're almost getting a digital trainer to help them with the clinical practice. And then once you're home, you usually have a lot of questions about your drug. So what we have also been doing is we've been installing these QR code on the medication drug box, where it will tell you, one, this is actually a legit drug, not a fake drug, because it tracks the supply chain information. But most important, that it will have a medication reminder to remind you when to take the drug. So you preset your calendar and your reminder, and on WeChat, you'll get a notification. And if you have an issue about this particular drug, you can also ask our AI on the mini program, and it'll give you specific answer about the specific drug. And once the patient come up, they usually have a bunch of medical reports that they don't understand. So we also develop a mini program where you take photos of it, it will structure into unstructured data into structured data, but then we'll also have AI to explain to you what some of the medical lingo terms mean. Because for most patients, those are foreign language. They don't understand what a radiology report says. But I think last but not least, what we're trying to do is we try to embed this into the doctor's workflow. So this is actually a video example of a real doctor talking to a real patient using WeCom, which is the business version of WeChat, so that they have an AI assistant on the right-hand side to guide them on the conversation and to support them in having the discussion with the patient. And so the last is, what we are also doing are now building digital avatar with doctors so they can better communicate with the patient, and just a short video to show you through what this is.
今天是2024年4月18日，欢迎大
So
家
we
来
are
到
now
医院
using
第
this
7次中
technology
层干部会
for
议。
patient education. So
请大家
education
尽快
doesn't
入
come
座，
from a tech
并将手
company.
机调
Now the
整至静
education
音或者
actually
正音
comes
模
from
式。
the
谢
doctors
谢。
themselves to the community, share in a private and safe way. So, so for this, I hopefully as a short 15-minute take you a world-round tour about what we're trying to do at Tencent to actually help change the China healthcare system. Thank you.
Well, thanks, Dr. Alex Nan talk about how to use WeChat as a platform to integrate a set of digital health tool to support the patients, support the doctor, support the hospital, support the managers of healthcare system to improve the performance of. So that WeChat, almost every Chinese has that WeChat, and also our project also use WeChat quite a lot in terms of our project. So actually, next presentation is me. I'm a double tasked. So, oops, it's not coming. Okay. So after the framework introduction, after the tool development, so I will give a real examples how those digital tools and AIs actually being used by the rural doctor in one of the poor rural area in China. This is one of the projects that the Gates Foundation is supporting in the last 6 years. Let's see. So the cases I'm brought in is one is called Yangqu County, which is in the northern part of China. Is the poverty county in China is one of the 500 poverty counties. So in this county, they have roughly 128,000 population with 10 township and 128 village. So when we talk about the primary health care, we talk about the This is the structure of health system in the rural China. So the primary health care is the first and the second, which cover the village as well as township health center. And then county hospital is considered the first level of referral. As Alex mentioned, giving the huge variation of training and the quality of care, a lot of people bypass the primary health care, go to hospital directly. So in order to address this challenge, and China and also this county introduced called a vertical integration, integrated delivery program. The name is called Cooperative Health Alliance. They established it 2017, which is a lot of, we can see this kind of vertical integration program happened in many Asia countries. In a lot of African countries, we kind of the integration is mostly horizontal, but this one is talk about how to integrate from a bottom primary healthcare community to a secondary care. So this is a 6 integration they propose under this system reform. I won't go to in detail because all the digital health as well as AI is supported by the system reform, because without the system support, all of these tools is very hard to use and supported. So giving that kind of a reform, they first developed the so-called integrated information system, which is break all the silos across the entire system from a village to the hospital. So every provider in the system can get into the information when people travel across different level of care. They can observe the information. At the same time, they introduced the digital health technology used at the community level as well as township level. So the digital health technology used at the community level is all-in-one health machine and AI-based medical assistant, telemedicine consultation, and the Medicaid decision training app. Those are 4 is being used at the village and township level. At the same time, they introduced the digital health technology at the township level. Besides this AI-based assistance, telemedicine, they have a remote imaging network, remote mobile ECG monitoring network, and a remote lab test system. Those are technology being used. For the information system, you can see they can gathering the information from apps, which is all the patients could have from WeChat. Right? So, and also they have all-in-one machine can bring to the home and get the people registered, and they can also receive the patients from their office. All this information enter into a database, so become information that all the providers across level can use. So here is the all-in-one health machine, which is about like a 5,000 renminbi per machine. And they can do blood pressure, blood glucose, blood oxygen, as well as some medical record input and so on. And also they can do ECG, remote ECG, and this ECG will transmit it to the center and then use AI to do the initial diagnosis and then send back to the village doctors. And this is another one called artificial AI-based medical assistant that is installed in the computer system. So there's a standardized the medical record, and then the doctor need to follow that. If it didn't follow that, then there will be warning to say, you didn't complete the medical record, you have to go back, ask a certain question based on the symptom. And they also gave the recommendation, what kind of diagnosis and the treatment and also non-medical treatment, which is education materials. And this is just as a second opinion for the medical doctor. Then the medical doctor has to decide whether they will follow or not. So this on the left side is about the uptake of use of this AI in at the village doctor's level. And then this is a telemedicine consultation, as I mentioned about the people, the rural doctor can use either telephone or videos to actually communicate with a higher level physicians to do call diagnosis and consultations. So this is the one I mentioned called telemedicine training apps, which is developed by one of the company in Wuhan called Zhiqu. And they used to develop this is basically a simulation, patient simulation model. So they develop a simulated patients in the apps in mobile phone. So then doctor can learn from this simulation patients to improve the quality of their diagnosis and the treatment. In the past, when I visited them, they don't have a module for primary health care. And now they developed a module of 10 major kind of medical condition at the primary health care. And then the doctor can use that to improve their knowledge as well as diagnosis and treatment skills. But at the same time, this tool can be used by manager to monitoring and test of the performance of the doctors. Now back to the imaging kind of network, as I mentioned about the imaging and the CGE and also the remote pharmacy, remote lab test. So all of this remote technology used made a service much easier to access because of the before without this kind of remote technologies, patients has to travel to the county level to receive it, and then now they can get it at the township and the village level, and also the price at the different level is different. So that's why when they receive this service at the lower level, it's save money to the insurance, save money from patients at the out of pocket, and especially save money for the government because they don't need to hire all the imaging doctors, all the lab test people at the lower level. So they actually save quite a lot of government salary payment by rolling out all these technologies. So in summary, we can see all this AI and the digital health system made quite a lot of achievement in terms of access, in terms of quality, in terms of cost reductions. There are a couple of challenges I would like to mention. That's why we need to improve the skill of the community health worker and health worker to actually adopting those digital health. One challenge we found is about the AI development. So AI is always using the real data to learn, and then there's a learning process. What we found if this AI is learned from the current health workers, if their quality of care is low, then it's become a garbage in, garbage out. How can you use low quality information to guide the health workers? I don't know if any other AI program for the primary healthcare found a similar kind of issue. So that's why there's a lot of debate in China whether they use AI or whether they should use a standardized protocol to guide the rural doctors' performance. That's one. The second one is increase the scope of work and workload. Because in the past, because without this technology assistant, the rural doctor just simply referral some of the patients upward. Now task shift to them, and they don't have those knowledge to actually, even their diagnosis from the AI, they actually still very vary whether they can really managing these patients or not. So there's a huge demand to train doctors for this new scope of work. So then suddenly there's a digital technology challenge about the system update and frequently, as well as the comparability of a different system. Insurance has their system, and the health system has their system, and the CDC has their system. How to harmonize this system, stability of internet, and the high upgrade and maintenance costs. Those are all some of the challenges. I stop here, and so I don't need to summarize myself. Maybe we go to the next presentation, Dr. Nelson Sewanka from Makara University in Rwanda. One thing I want to just mention here, everybody know the AIDS. Actually, Dr. Nelson actually is one of the person helped identify the HIV AIDS back to 1981 in Rwanda. He's one of the pioneer on the HIV discovery. Yeah.
Wow. So good afternoon, ladies and gentlemen. Thank you for that very kind introduction. Yes, I'm from Makerere University in Uganda, and I stand here not to talk about Uganda, but give a broad picture, a continental picture. The title of my presentation, as you see, is AfriHealth, Africa's Opportunity. Africa's opportunity, and I emphasize that, for bridging continental inequalities in health in an age of artificial intelligence. One of our persistent concerns is about inequities. And just to remind you, as we experienced in COVID not too long ago, inequities affected many of our countries and certainly Africa. And we don't want that to be a persistent, serious issue. We need to bridge those inequities in health. And we think that artificial intelligence gives us a great opportunity to make some inroads on that. And of course, this technology, for this technology to work well, we need tech-empowered health workers. Now, the African Union is that continental organization that brings together all the countries on the continent as one group, African Union. Just like you would say, the United States brings all these different states together. The European Union brings together all these different countries. So there is the African Union. Two of the important ideas that the African Union is expounding or using to see that there is greater development on the continent are, of course, the SDGs, which you know very well, and which were expected to perhaps end in 2030, and we are not too far from that. But Africa has got an African Union agenda, which runs parallel but integrated together with the SDGs. The African Union agenda is expected to run up to 2063. It started sometime back, a little earlier than the SDGs, and this one is going on to 2063. So the Union agenda gives us a much longer view of developments in Africa, a view that goes beyond 2030. Now, what is AI's potential in Africa? Many people look at Africa as a black continent, as a continent which is is not so functional. We don't look at it that way because we've done things in Africa that have informed the world, and the world has learned from what we do. One of the opportunities on the continent is that the young people are increasingly digital literate. And of course, I expect in other countries too the same. But Africa is no exception. And the younger health workforce are very digitally literate. I was a dean of the School of Medicine at Makerere University for 12 years, and thereafter I headed a College of Health Science, which includes 5 or 6 schools: medicine, public health, biomedical sciences, nursing, pharmacy, and so on. And I used to have informal discussions on the weekend with the students who were interested. In this context, they would say, "Professor, some of your faculty are a problem." So, wow, tell me more. You know, we have our smartphones, and on the ward and in the outpatients, we are using our smartphones. But some of your faculty, they say, "Oh, you know, put away those tools because you are just chatting with your girlfriend or boyfriend." And yet we are using them to access information. So younger people are obviously more digital literate, but the older professionals are not as much. And yet, even the policymakers are older, and they hold the authority to change policies in the country. So there is a dilemma there. How do we make the older people also believe, first of all, in digital literacy and also become digital literate? Now, 2 days ago, I'm sure this is common news, the DeepSeek was announced from China 2 days ago. Yeah. Which is the counterpart or the equivalent of ChatGPT. And even in Uganda, where I come from, people are talking about this DeepSeek. While I'm here, I've got so many mails from different people and students talking about this. And they're excited. So we don't want to get into a situation where global health has been on the radar. People have been talking global health, global health, global health, and people from the high-income countries have been flocking to our countries, students and faculty, to do work in global health. And yet our people were not so impressed with global health. And they said, "But what we're doing every day is global health. What are you telling us about global health?" So we don't seem to have benefited as much as the high-income countries in global health, but we don't want to lose out on artificial intelligence. Now, what is the context on the continent? Of course, these unsatisfactory health services in many places. There's the urban-rural divide in access to services. Rural areas are not attractive to work in. The scarcity of professionals or health workers, and yet there are rapid changes in technology regarding diagnostics and treatment and so forth, as we know elsewhere. And we do have weak technological resources. Computers are not as common as they are in the more developed places. And there's suboptimal integration of technologies in the health system. That is a big challenge. So with AI, how are we going to integrate if the technologies are not embedded in the health system? One of the common problems is sustainability of introduction of new ways, new approaches of doing business in the health system because of low funding, because of low expertise that exists. But with AI, we are thinking we must make sure that we think ahead on how these are going to be sustained. There are, of course, islands of excellence on the continent, and we think these will give us, will leapfrog us into the use of AI. In fact, we should be in a better place if there was a lot of South-to-South collaboration within Africa itself, so that we use our islands of excellence to the maximum. Last decade gives us a lot of hope that we can actually leapfrog into artificial intelligence. Some of the things that happened during that the last decade, there were innovations in MEPI, NEPI programs, and I'll talk a little more about that later. There was what we call a program we called H3 Africa, which focused on genetics and genomic research. At the beginning, there are not so many people interested in doing research in that direction, or people who thought that there were not so many who thought that genetics and genomics will be very relevant in the healthcare system. But with grants from the National Institutes of Health in the United States, people are now running all over the place, embedded, doing work in this direction. There are data science innovations that have been funded again from the Western world. And people are very busy using data science to inform or to develop artificial intelligence. Our academic institutions are increasingly, they have, in the last decade, it's been exceptional. Greater focus on innovations. The language is innovations. Institutions, you go say innovations. What are the innovations? Countries have increased their attention to the value of science, and they are embedding or putting more resources into science. The last one is Africa CDC. You may all have heard about the Africa Centers for Disease Control, similar to the United States Centers for Disease Control, and it's doing wonders on the continent. In fact, people are coming from all over the place to say, let's see, we want to see how this Africa CDC lands, does its business. And so there's plenty that we can learn from. Africa CDC was actually accelerated by a COVID epidemic, saying we must do more work in order to prepare for the next epidemic and the next pandemics. So AfriHealth, which I said at the beginning, can give us a forum where we develop artificial intelligence that we need on the continent. The AfriHealth is the African Forum for Research and Education in Health. AfriHealth platform, by the way, in front of you is a map of Africa. Is an ambitious undertaking. It brings universities together from the entire continent, from all countries, whether speaking English, whether Arabic or Portuguese, Spanish, and so on. Because it brings us together, it gives us an opportunity, therefore, to harness resources which exist everywhere. 2 more minutes. We started mobile phones, very simple technology. We started mobile phones the last 5 years to see how mobile phones are used in health. And what we went for is the informal use. How do health workers use mobile phone? It was their innovation. They started using mobile phones to deliver better health services. And it is very interesting to see that health workers, even at the village level, community health workers, are deeply attached to mobile phones to drive the quality of work. It has been stated that fixed phones took 75 years to reach 100 million users globally. That mobile phones reached the same target in 16 years. Internet took 7 years to reach a similar number of users. ChatGPT took 2 months to reach those numbers. Chinese DeepSeek, which started 2 days ago, I don't know how many days it is going to take to reach the same number of users. At that speed, Africa must not sleep. This is my last slide. We have an opportunity to build on the Medical Education Partnership, MEPI, and the Nursing Education Partnership Initiative, because they had lots of achievements in the last decade to create expert critical mass in our countries, lead innovators for countries or regions in Africa, and bridge the gap between these countries. We, at the end of the day, as we go on, we should train AI on data from Africa. And yes, the question of quality of data has been touched upon, but we want to make sure that the data we use in developing artificial intelligence is high quality data. And by using data from Africa, we overcome the usual problem that data from Africa is underrepresented in many initiatives around the world. And therefore, we get a distorted picture of what is happening in Africa. AI gives us that opportunity to use our own data that comes from Africa. Thank you very much.
So, Professor Nielsen Sawanka actually brought a very important issue about equity. That's one of the major theme of this symposium, and we're all excited about the technology development, then how we can make sure all this technology can be used by all people, not just the rich, but also vulnerable population. And he also brought about the challenge and the opportunity in Africa of utilize this AI and the new technology. More importantly, he brought about the South-South collaboration opportunity. I recall in our organizational committee, I actually raised this question that if PMAC really want to be a global platform, a global conference, we should encourage more and more South-South collaboration. I'm so glad that Professor Nielsen Sawanka can come and share his view about this issue. So our next presentation speakers is Dr. Derek Moni from WHO Geneva. I believe he's online. Okay, he's the head of capacity building and collaboration of the Digital Health and Innovation Department at the WHO Geneva, and he's going to present a topic about capacity building of using digital health and AI in improving health system performance. Over to you.
Thank you so much, Hong. Just want to check if you can hear me. All right, if you can all hear me, then I will start the session. Obviously, you're all in the room, so want to say good afternoon. It's morning time here in Geneva. And for those online, would say good afternoon, morning, and evening, depending on where you are, as the case might be. I just want to thank the speakers that have spoken before me. There has been very great synergies formed in the presentation that you'll be hearing about and what we just heard just now. I'll be sharing my screen to speak to this presentation. So you will give me a moment to display my screen. I hope the clock is ticking whilst I'm doing. I hope the clock is not ticking whilst I'm doing this. Okay. If you can see my screen, I will continue speaking. Do let me know, Hong, if my screen is not showing. Can you see my screen? All right, I will try to share again. Here we are, and share screen. Can you see my screen now?
No, not yet. Not yet. So let's. Oh, yes.
Oh,
Okay.
all right. All right. Thank you
Okay.
so much. As has been introduced, my name is Derek Munene. I'm leading a team on capacity building and partnerships. This particular topic is central to my unit's work and also the overall agenda of the global strategy on digital health. We recognize the power of health workers and the affiliated actors in the transformation agenda on digital health. And as we all know, transforming a sector is three things. It's a people skills, it's a technology, and also the processes. At WHO, our Director General has underscored the need to invest in artificial intelligence and also the need to invest in the overall agenda of digital transformation. At one of the executive boards, our Director General once mentioned that the future of health is indeed digital and called upon member states, WHO, to really embrace it. But more also, as has been highlighted in the previous speaker, AI is beginning actually, AI is continuing to play an important role in ensuring that health systems are robust, resilient, and also not only reactive, but responsive to emerging needs of the health system. And so at WHO, AI is central to our work. We have received a lot of interest in our AI courses and also in our AI publications. And at the same time, our mandate in terms of supporting member states through our current general program of work includes digital in a number of areas. And so the 3 Ps that our program of work sits on, which is to promote health, provide health, and protect health, are all integrate digital in the implementation of those actors. And so our key mandate at WHO is really to ensure that member states have the needed resources and tools to transform health systems in pursuit of universal health coverage, and also ensuring that these digital solutions are science-based and they're really based upon the needs of countries. We are celebrating 2 decades. 2025 is 20 years of responding to and supporting member states on the agenda of digital health, beginning in 2005 when they gave us an e-health resolution, to 2013 when they gave us a resolution on standards and interoperability, and in 2018 when they gave us a resolution on digital health that has had a specific urge to member states to build capacity, especially using digital means for health workers, but also the actors in the ministries of ICT. This particular resolution is key to us. It has a number of pillars that I'll speak to. But at the midpoint in 2015, we had conducted our last global survey. We're planning to conduct a complementary one soon. In 2015, at the midpoint of our now 20-year journey, we realized that a number of countries, 3/4 at least, had integrated pre-service training on e-health and continuing professional educational training mechanisms, both in the health sector, but also in the ICT sector. And the ICTs at that midpoint were being integrated already in pre-service and in-service modalities. This is something that we're building upon, and looking at the spread across the 6 WHO regions, you can see, as the chart shows, that at that midpoint of 2015, a number of countries had already started investing in ICTs for health across all the regions. And social media was quite prominent then, and so a number of countries had started already integrating social media. And so with the 2018 resolution, the Global Strategy on Digital Health was enacted. It's a 5-year strategy. It expires this year, and we've proposed a renewal. That strategy is really around universal health coverage, ensuring that the digital transformation leaves no one behind and reaches especially marginalized populations. There are 4 pillars. One is collaboration and capacity building, which is really what we're talking about, the need to ensure that we have a future-proof, digitally ready health workforce. Objective number 2 is around integrating digital health interventions into national strategies. So when there's a strategy on capacity building, that has to be articulated in a national strategy itself. Third objective is around governance of the digital health transformation agenda. That includes being able to measure the maturity of a country's transformation agenda. And then last is around people-centered health services, including digital health literacy. So the ability to use and engage ICT skills and resources is in that 4th objective. One of the policy actions that I'll draw attention to in strategic objective number 3 is around approaching digital health capacity building through a competence-based approach. And then policy option number 4 is around ensuring that digital health reaches all actors, from policymakers, planners, including developers, practitioners, and the general population. And so with these, we're building a competency framework. This resonates very well with what Kate presented at the beginning. And so our competence-based approach from the strategy is really ensuring that knowledge, skills, and attitudes are articulated for all the actors, the policymakers, planners, and the practitioners, and that the courses being built are really based upon this competency-based approach. We're excited that at the UN level, member states approved last year at the UN General Assembly a global digital compact that emphasizes competencies for digital skills and competencies associated with those. And so we are working with the member states that propose this compact, negotiated by Zambia and Sweden. And so this particular digital compact is a foundation towards our global digital health competency framework. Throughout our journey supporting member states, we have emphasized member states to focus their digital strategies on 7 pillars: leadership and governance articulated in a national strategy, and funding for that strategy well articulated as an action item, including a portfolio of digital health solutions like electronic medical records that are fit for purpose, and investments and articulation of standards for interoperability, including infrastructure and legislation. One of the pillars is around addressing workforce. What are the needs of the workforce in terms of training for them to carry out the aspirations of a country's strategy? These 7 pillars inform the development of a national strategy, the investment roadmap, including the enterprise architecture, together with the applications that are needed to carry out a country's foundation, country's national digital transformation agenda. And so the 7 pillars, including workforce, are really foundational, and it's key that we focus, really making sure we focus on this particular area of health workforce to ensure that the transformation that we're looking for is sustainable. Globally, we have a global digital health monitor where we measure the penetration of the 7 building blocks. And as you can see, one of the lagging areas, this is 2024 data, one of the areas that are lagging behind of the 7 building blocks is workforce. Many countries are still working on curricula, many countries are still, integrating digital health skills in pre-service and in-service. And so what we're doing at WHO, therefore, in our capacity building agenda is really building courses that are aligned to a competency framework for pre-service cadres, in-service cadres, and any emerging roles, such as what we're seeing, emerging in countries, the formation of digital health agencies. And so really getting back to the whole issue of how we actually ensure that training is fit for purpose for all actors. Our approach as WHO is really really developing a competence-based approach that articulates the needs of the audience. And our audience, as mentioned, are the 4 Ps: policymakers, planners, practitioners, and the general population. And so the roadmap towards the digital transformation of the health workforce is really enshrined around identifying the activities and roles of the different actors, both those actors in the ministries of health and also in the ministries of ICT. We have already filled in gaps where training opportunities for actors are missing. This particular course on digital health planning national systems is really targeted on the middle layer of that pyramid, the planners of digital health systems, the national coordinators working at the national and sub-national level. This course has already seen a lot of uptake. We hit the mark of 1,000 learners last year. It's reached all the 6 WHO regions, and it has been deployed at the WHO Academy and translated in at least 75% of the UN languages. Available for free. The content is in the open source domain. And so different interest groups can actually use the slides, modify them as needed, and adapt as needed. There is also a course on artificial intelligence, ethics, and governance that was launched 2 years ago. It received 17,000 enrollments just before the launch itself. We have launched the Global Initiative on Digital Health to ensure coordination on learning content, creation of courses, including the competency framework. The Global Initiative on Digital Health is really 4 pillars. What are the country needs? What resources are available to support those needs? What tools are available, including courses aligned with the competency framework? And what avenues can we socialize these elements, such as the meeting that we're having right now? So the Global Initiative on Digital Health is our vehicle of coordination. And to just maybe recap the 7 things of this presentation that I would like to just share as takeaway messages. We definitely believe that transformation of the health sector requires people skills and articulation of knowledge, skills, and attitudes. And these would lead to safe usage of medical record systems, for example, creation of personal health records that are usable by health workers and also by citizens. And to really enforce the whole issue and the need of enforcing the continuum of care or enabling the continuum of care so that patients and health seekers can enjoy access to their medical records wherever they are. Item number 3 is that we really must embrace the opportunity of a digital public infrastructure through enabling digital financing and also tracking payments. And then area number 4 is really embracing supply chain management. And to do this, of course, the different actors involved in this field must be digitally capable. Area number 5 is around the whole issue of this meeting, the issue of preparing a digitally ready, future-proof health workforce that is adaptable, that is literate, and that can engage in a meaningful way with the digital health products. Area number 3 is around harnessing the power of AI, as has been mentioned by previous speakers. AI, which has been a field that's been with us for 50 years now. 1950s AI was introduced, but we're now seeing a lot of uptake. And so we need to embrace the current momentum on AI in a meaningful and safe manner. And then area number 5 is around the whole issue of strengthening public health planning and surveillance and also response to systems. Just want to announce the digital health competency framework that I talked about is intended to be released just before the next World Health Assembly. There will be a public comment, and so we invite comments from the audience in this particular meeting to engage with the competency framework. We anticipate to receive your feedback. We do plan to have a public launch at the next UN General Assembly in September. And so stay tuned. The WHO website will have all this information. We'll be posting the schedule I've just talked about on the WHO page in the coming week. Thank you so much. I realized that I'm speaking virtually, so I couldn't hear the bell. Apologies if the bell rang whilst I was speaking. But want to just hand over the floor now back to Hong and wishing everybody a successful deliberation. I'll stay tuned for the Q&A session when it comes. Thank you so much, and over to you.
Thank you, Dr. Derek Moni, for such a intense and full-packed information. I'm sure people are going to process. I think within 12 minutes, he talked about the 20 years of history of WHO supporting the digital health and AI and the strategy and the guidelines and the activity and especially trainings, materials. So we will have probably spend more time to digest what he presented. And I hope you can make your slides available to all the participants as well. Our final speaker will be Professor Bill Hush. He's from Oregon Health and Science University. He is a professor in the Department of Medical Informatics and Clinical Epidemiology. Floor yours. He's talking about education and research.
Great. Thank you. Okay, well, we're running behind, and actually I originally thought I was doing a 15-minute talk, so I'm going to try to go through some slides quickly to cut things down. These slides are on my website. The last slide has the link. It's billhirsch.info. You can Google me, or I can send them to you. I'm going to talk about work that I've done over the years around developing competencies and curricula in health, clinical, biomedical informatics. Informatics and digital health are very similar. I prefer the word informatics, but maybe we can debate that later. I actually spoke at this conference 15 years ago, 2010, and actually spoke about very similar kinds of things. So what I'm going to try to talk about in now down to 11 minutes is just giving an overview of informatics. I'll probably whiz through that. I'll talk about the competencies and curricula for the different types of learners. What is the role of AI? I am American, so this is a somewhat US-centric view, but I'm always interested to hear what people in other countries are doing, like we've already heard. So health or clinical informatics is an interdisciplinary field that requires understanding not only of biomedicine and healthcare, but also computational things, computer science, data science, and more recent years, machine learning and AI. There's a diverse workforce in terms of there are researchers, there are developers, implementers, and of course, users. And the educational needs of those groups are different depending on what they do and how they're using informatics. These I'm going to go through really quickly, just kind of reiterating that informatics isn't just the sum of all these. All the interactions make it something that has unique aspects to it. And my colleague Chuck Friedman has coined the fundamental theorem of informatics, which is that the goal is to help the human and not to be better than the human, although some may argue that AI is starting to do some of that. But really the goal is to help humans who work in healthcare, including patients, do their jobs better. So there are many different types of learners who have different needs, not only practitioners, but students and so forth. There's been a lot written. This is just a bunch of references on the competencies in informatics for people who work in informatics. Again, it's this overlap of knowledge around health and biomedicine, knowledge around information and data science, and also aspects of social and behavioral science. Informatics does not operate in a technology vacuum. The American Medical Informatics Association has looked at the skills of people who work in informatics, mostly US-centric, although certainly my experience is that these are really international in scope, and the work that people do in informatics in countries outside the US is not that different from what we do in the US. So how do people achieve competence and become trained and skilled and in some instances certified in informatics? It's mostly a graduate level field, so master's, PhD degrees. Some people are trained through fellowship programs. One not so recent, it's about 10 years old now, but there's a physician subspecialty of clinical informatics. You can add the clinical informatics subspecialty to your primary specialty of internal medicine, pediatrics, radiology, et cetera. There's a growing number of baccalaureate programs in the US. I know there's a lot elsewhere in the world. And then there's also individual courses. And one of the things that I'm fairly well known for is this online introductory course that I've taught, basically demonstrating the value of online learning, repackaging it for different audiences. So it's the introductory course that people take when they're coming into the field of informatics, but it's also, for example, an elective for medical students. It's also taught as a continuing education course for clinicians mainly, although really anyone who wants to take it to gain more knowledge in this field. I recently tacked the phrase artificial intelligence onto the title of the course, perhaps reflecting how large that has been becoming. One name for this course that some people might know of is 10 by 10. The chair of the board of the directors of the American Medical Informatics Association back in the mid-2000s said we should have at least one physician and one nurse trained in informatics in the United States in each of the 6,000 hospitals. So kind of playing around with the numbers, we came up with 10 by 10. So we could train 10,000 people by 2010. But 10,000 people didn't come forward, but actually 1,000 did. And not only that, but people continue to be interested in this course, and it still is offered several times a year, and 3,300 people have completed it dating back to 2005. A number of them actually go on to graduate studies, so to further study. And if you're interested in the details of the course, you could follow this link. This basically is the topic overview of the course, so it probably shouldn't surprise any of you who know informatics or digital health. It's about the problems that motivate the use of technology. It's about electronic health records, personal health records, the all-important data standards and interoperability. Even though AI is infused elsewhere in the course, there's one of the units that's specific to it. Some of the more advanced uses of the electronic health record, implementation, security issues, evaluation, telehealth is also in there. Of course, informatics is not only about electronic health records, so information retrieval or search systems, research informatics, how we use informatics to conduct research, and then other areas, public health, nursing, consumer health informatics. So this course has really, again, the central course is the graduate course, but it's been adapted for actually an undergraduate course at Portland State University nearby where my university is. The Office of the National Coordinator developed a curriculum that includes that we contributed to. I mentioned 10 by 10, a course for researchers, and we've also done it internationally. One of my projects I'm involved with is the Data Science Initiative for Africa. It's funded by the U.S. National Institutes of Health and awarded about 40 grants to different universities and others around Africa to build capacity in data science. And so we use the course in that program. It's also been translated into Spanish by my colleague, Dr. Paulo Otero from Hospital Italiano in Buenos Aires. And of course, it started as just a plain translation, but it's really evolved to reflect much more of the way healthcare is in Latin America, mainly in Argentina. In terms of the online course, the teaching modalities, I spend a lot of time talking into my computer, basically giving voice over PowerPoint lectures, breaking them down into pieces, and with modern technology, viewable on any kind of device. There's assessments in there. There's interaction. Teaching is, even online teaching is not just putting materials up, but you want to have interaction with the professor, between the students. And sometimes, depending on the situation, we use a flipped classroom where students listen to the lecture ahead of time and then come to class prepared to discuss it. And I sometimes assign some students review one of the topics and ask a discussion question about it. And I'm the editor of a textbook in health informatics that is optional. We don't require it for this course. But of course, informatics is not just for those who work professionally. I've been involved a lot over the years with informatics in medical school curricula and other fields, nursing, dentistry, and so forth, but mainly focused on medicine, research scientists. And of course, patients also need to be competent in informatics. Some have argued connectivity is another social determinant of health. And community health workers, which is talked about in the overview of this session. I led the publication of a set of competencies for medical education, although it really applies for any health professions education, but knowing how to use an electronic health record, knowing how to search and find information and apply it, issues, you can read through the list of privacy, maintaining patient privacy and security, quality measurement, safety issues, health information exchange across boundaries. And you go all the way down to the bottom, which was not in the original paper in 2014, but has since been added to this list, to be able to use and critique AI. And I think that's a real important skill. Medical students don't need to know all the detailed mathematics and the neural networks. Actually, most informatics people don't know it either. But it's kind of like a car. It helps you don't necessarily need to understand all the details under the hood, but you need to know how to drive it and some of those issues. And I think one of the big challenges in the years ahead is understanding both the accomplishments and then also the drawbacks, the data biases, algorithm biases, equity issues, and so forth around AI. I'll make a last couple of comments about the role of AI in education of health professionals. There's the good and the bad. One of my favorite authors is a business professor from the University of Pennsylvania, Ethan Mollick. He publishes a Substack. He's described all the ways that you can use generative AI, and we've seen some examples of it in the previous talks, as a mentor, a tutor, a coach, and so forth. But as a teacher, you run into problems, and I published a paper a few months ago about this. The green, the orange, and the blue lines are the 75th, 50th, and 25th percentile of the 139 people who took my introductory course in 2023. And you see how they scored in the different unit assessments in the final exam. The black is just because it happened to do best. All the other large language models did almost as good in how they did with simple prompting, just like dumping the questions into ChatGPT and Google Gemini. And as you can see, scored at about the 75th percentile, so better than 3/4 of the students. And that raises, and on the final exam, the ChatGPT did the final exam in a minute. We usually give students 2 hours. So for those of us who want to assess students and learning, we have to, I have one more slide after this, I promise I'll go quick. How do we assess students now in this era when they can just take their assignments and dump them into ChatGPT or Google Gemini or whatever, or DeepSeek? I haven't done that one yet, but it'll be interesting to see. The final thing I want to mention is another topic of importance to me, which is searching for information and really what comes out of large language models. They give us the answers, but they don't necessarily give us the references. As we're making life and death decisions as clinicians, we don't just want the answer, but we want to know the information behind it, even routine decisions that we make. And large language models don't do that. And I don't have time to really talk about this study, but people have looked at this, and the large language models don't do particularly good at citing their sources, even though their answers have a high rate of correctness. But I think we still should want to know where that information comes from. So I will stop at that point. If you go to www.billhirsch.info, you can find these slides and all kinds of other stuff. And I guess we're done.
I wish I were 18 years old again, so I can go to university to study such a broad knowledge, and at least some of our audience who are older enough who can identify who has the competency to do right work rather than do by ourselves. So let's give a round of applause to all the speakers for such impressive presentation. So we have 25 minutes left for Q&A. I would like to invite all the speakers to the podium so we can invite the questions or comments from audience. Another, my colleague, former colleague at the Gates Foundation. Please, go ahead.
Now it is, yeah. Hi, Stefano Bertozzi from UC Berkeley, formerly from the Gates Foundation, a long time ago. I was just curious for the last speaker. All of us who teach are struggling with assessment, and you just touched on it at the very end, so I wanted to give you a little bit more time. I've been very hopeful, but now for too long, that AI will help us with assessments by creating simulations that we can use to assess students in a more realistic way, similar to what you might do in an oral exam, where you can respond actively to what the student is doing. We're not there yet, and we're in this sort of gulf where the AI does better than 90% of my students do, and I want to say to them, how could you do worse than the thing that you have available for a take-home exam? But I'm curious to know what your thoughts are on where we're going to go with assessment. Thanks.
Yeah, thank you.
We collect the 3 questions, then we invite the speaker to respond.
Okay. Good afternoon, everyone. My name is Papat, fifth-year medical student from Siriras Hospital. So I would like to ask Alex, when you're using the WeChat for at-home data collections, how do you address the privacy concerns and also the regulatory challenges? Given that I understand that China have a strict health data regulations similar to Thailand context. So how does your team navigate these obstacles during the development phase? Thank you.
Please.
Sure. Thank you to all of the panelists and speakers. Kalei Hosaka from UCLA. I have a 2-part question, if that's okay. First, really for the panel, I would love to hear more what AI could look like in the context of medical training. Dr. Siwon Kambo, you mentioned students bringing a phone on rounds. I'm curious to hear, not just being able to answer questions in a graduate level class, but also as we train physicians, what potential benefits, what potential barriers are there? And then secondly, in the era of prosumerism, as mentioned this morning, where with patients taking more ownership of health, or potentially asking large language models about health, and clinicians potentially being in conflict with what patients bring to the table from a prosumerism or that approach. I'm just curious to hear from the panel, how do we empower the workforce when there could be potential conflicts? Thank you.
Okay. Yeah, well, I was actually going to go into a little bit more detail. I mean, you could almost use the word crisis. I mean, actually, Ethan Malik, who I mentioned, has coined the term homework apocalypse, because a lot of traditional homework assignments. I think the challenge is in, we really need to kind of rethink the whole approach to learning, because just because you can go to ChatGPT and get this answer out, does that mean you understand it? I think there probably is a foundation of knowledge that we need to master, before we start using these tools for more specific things. It's a challenge, and I think that really the whole educational world really needs to figure out. I mean, some people say, well, let's just go back to paper and pencil tests, but you can't really do that in an online course. I've actually, I give talks like this hoping people will give me the answers, and I still don't know what the answers are. So if you or others have any, I would love to hear them. But I think it's important that all people, including patients, like the last questioner just said, know how to use these tools and their limitations so people can use them most effectively.
I'd like to address that question as well. I think you're right. AI can be used to create simulations, and we need to keep in mind when people think of simulations, they usually think of the very sophisticated models. For example, we had a medical education session yesterday at which Dr. Nelson spoke as well, and one of the Thai teams presented a very sophisticated VR, full immersion anatomical model that they had that took years to develop. But a simulation can be as simple as a written case study. And ChatGPT is very good at creating these types of things, and so you can use it to create even very simple simulations. It doesn't have to be advanced. And I think that it's important to let students know that when they're working on the fly, when they're in front of a customer, when they're in front of a client, in front of a patient, they can't turn to ChatGPT. So they need to know the material. And also, as I think was mentioned this morning, there needs to be a human that's going to look at everything that's created by AI to make sure it makes sense. There are no hallucinations. So the human does need to know the content. And the ChatGPT is going to be doing a lot of the sort of the easy, the repetitive work, but the humans need to know and understand. Now, for homework that's sent home, that is a challenge. And I think I would address it by saying, first, do it by yourself. You need to think critically, you need to gain those skills, and then put it into ChatGPT and see how it's different and learn from that, learn from the response. But I strongly believe that for a lot of tests, especially final tests, that it needs to be without computers at all. And there are now a lot of proctoring softwares. We work with a company called Lecturio that they can lock the person's home computer. They can look at the person's eye movements. They can look at the way the keyboard is used, and so they can tell whether someone's cheating or not, whether someone's has a laptop on the side or is opening another window. So I do think that there are ways that we can proctor people even on remote courses.
Sure. And the question, so this question comes up all the time about privacy, especially around tech company and how we use. And the way that we approach it, if you see in my presentation, there's certain AI and information that is basically open on the World Wide Web, right? Where people just access information or use AI to, let's say, to ask how a drug is being used, right? Where the AI is very useful in giving them a response. But for the more very, very clinically sensitive one, let's say the history-taking chatbot. So what we've done is, yes, we have built this chatbot, but what we did is we locally deployed this into the hospital service. So the hospital actually maintain the integrity of the question and answer. Of course, we do a lot of testing so that it applies to their context, but then everything else after that, the data, everything's actually still housed within the hospital environment. Because we actually believe that in those cases, right, where in some way, as a tech company, we don't need and we don't want to be burdened with that sensitive information. So from a technological route perspective, we have sort of made a very conscious choice on two parts. On one thing is where a public will want to better access information that will otherwise be available on the internet. Of course, that will be hosted by us. We're giving them the answer as quickly as possible. For the very clinically relevant one, we actually put the entire model back onto the hospital server. So they maintain it, they have the database, they draw on it, they call us for technical support if something goes wrong, but essentially they are responsible for maintaining those.
Can I? Yes. So the question of using ChatGPT, for example, in education is still a very market area in my institution and in many institutions around the continent. When you talk to people from different institutions, they are also challenged as to how to approach this area. Now, as I said in my talk, the younger individuals, students, not only the undergraduates, but the master's students, even doctoral students, they are using those tools. When you ask around the class how many people are using the tools, literally the whole class just puts up their hands. They cannot hold back. One of the things that is problematic is that the institutions are lagging very much behind in producing guidelines, in producing policies on how students should go about this. And even the teachers themselves, they are lagging behind, and therefore we find ourselves at crossroads. However, it's important to explain to the students, and some get it well, that if they just run around using these tools, they end up not benefiting themselves. They are the losers. They should appreciate that they need to learn and not simply jumping to using these tools and get away with it.
Yeah, no, I understand. I mean, I think it's important, even before generative AI, I think it's important, we've long surpassed, when I was in medical school, you have to memorize everything in your brain. We've long passed that. There's no way that any person can memorize all of medicine anymore. So we need these information tools. And so, we need to find ways to incorporate them into practice and then train people to use them. But again, still, there is that some fundamental knowledge that people need to have in their heads.
Thank you. Let's invite another round of questions. Please.
Thank you very much. My name is Dr. Noda from Japan, working for the National Center of Global Health and Medicine. And I was so impressed with the presentation by the second speaker, especially the diagnostic support tool. And I think that now it's MCD is a very heavy burden. Then the primary health care worker, especially the nurse working in the peripheral level, I think that they need the diagnostic support tool. Then, my question is toward to the WHO. And so WHO is developing a lot of the tool, then which is including this kind of the diagnostic supporting tool, especially for the nurse working in a primary healthcare setting. This is a question to the WHO. Thank you very much.
Hi, I'm Juhama Ratanapongwanit from Ramativati Hospital. Yeah, and I have the question that, as you had mentioned, that you use AI chatbot for giving medical advice for patient on online platform. And I really wonder that, how do you build trust and reliability among patients when you use that AI chatbot? And moreover, how do you ensure the accuracy of the advice provided to prevent like misdiagnosis or inappropriate medical treatment to patient? I really wonder that. Thank you.
Hi, my name is Asif Saleh. I'm with BRAC in Bangladesh. And my question is for Alex. Your presentation was very impressive. And it's probably the first kind of very comprehensive usage of AI and technology I've seen to comprehensively tackle the problem, both of equity and quality and access. My question is twofold. One, you said that one of the things what's very helpful for rural doctors is to improve the quality by using the AI, the diagnostic tools. Question was like, of course, you run a private entity, so your biggest beneficiary would be the city-based people. But for the rural sort of audience, have you run any numbers to see whether that actually solves that problem of access and quality in terms of impact from an equity perspective? And the second question is, you seem to have cracked it. I mean, so is there any plan to take it outside China? Because many countries, like whether it's Bangladesh or other places, have very similar issues like you mentioned in China, whether everybody has to migrate to city for better quality treatment and all the doctors are concentrated in the cities. So thank you.
Some question to Alex and also to, yeah, go there. Okay. Derek, you want to?
Yeah, thanks. Yes, I can go first, actually. A great conversation, actually. Great points coming out from the floor and also from the panelists. I particularly enjoyed the question around how learning is actually changing, given the wide availability of tools on the internet. And so classroom arrangements are actually getting expanded to virtual platforms. The whole issue around AI and diagnostics tools and WHO's work in this area, I would be very keen to actually stress the point that the place of diagnostic tools, especially those that are AI enabled within the health system, is best placed in those areas that have skills shortages. So remote areas, for example, places where you don't have expertise. And as WHO, we have promoted the whole issue of reaching the marginalized using AI-enabled tools, especially diagnostics. Now, before generative AI, countries were uptaking tools that support diagnosis. For example, image analysis is one of the use cases that countries were actually keen to adapt because of its ability to fill the gap of expertise in terms of places where you have shortages. Our role as WHO is not to provide these kinds of tools, but the standards by which the tools making the diagnosis or the presentation of opinions. That's WHO's mandate, really looking at the standards that are associated with these kinds of tools. We have done some work in this area with the International Telecommunications Union. Senegal is a good example where we have image analysis for eyes to provide for early detection of diabetes. And again, with that particular intervention, our emphasis is on the classification of the diagnosis, making sure that the end result of the recommendation or the diagnosis is complied with how WHO recommends the manifestation of a diagnosis through the International Classification of Diseases, for example, and other standards-based recommendations of health outcomes. And so that's the place of WHO. It's really normative, providing that foundation of standards so that there is consistency in the presentation of health outcomes. Thanks so much.
So I'm taking a question about the quality improvement. As my presentation, I mentioned in the rural poor area of China, actually used the AI medical assistant tool that they developed by one of the company. And we do observe that, for example, their record, the medical record quality improved, and diagnosis and the treatment recommendation from AI assistant become more and more acceptable. Then you can improve the quality. You can improve homogeneity of the treatment and diagnosis at the remote area. As I knew that the Minister of Health in China actually discussing with the 4 major industrials to trying to develop this medical assistant tool. I don't know, Tencent would be well or not. That's one thing I want to chat with you. But they're developing and trying to develop nationwide kind of tools. Right now, it's still not nationwide yet. It's being tested in different places. But in terms of the question whether this tool can be introduced outside of the China, I recall that Alex and I actually visited a Babylon program in London's office. The algorithm, the tool itself is applicable in other country, but you have to collect the the learning process. The data system has to come from the local because the disease pattern difference and the challenges difference. The machine learning has to be localized. So that's what I understood. Thank you. Do we have we have a question?
Oh.
Go ahead.
Oh, I was just going to answer the two
okay,
questions.
Please.
I think my experience in developing AI is a very broad word. And because I'm actually more interested in building scalable applications. And the way that, in my experience, found that it worked, you really have to pinpoint the setting and narrow down how to use it. Just example, just throwing up entire patient's history into ChatGPT is pretty much useless for most doctors. And that's why, if you can see my presentation, we carefully segment sort of the workflow bit by bit. The reason why is because we want predictability and reproducibility. Because I think this is the only way where you can get trust from the system, that you're going to get the same outcome that is being vetted and quality controlled, so that then they can trust it and say, well, I can now offload this workload. I can now depend on it, because I think this is what people sometimes miss all the time. And that's why you see the chatbot as a chatbot. It's not there to give you a differential diagnosis on what the patient has. We have that AI. We can do it if we want to do, but we chose not to. But if we actually have that, we'll be not giving it directly to the patient, but we'll be giving it as an advice, as a recommendation to the physician, so that they can then put in additional information that is not privy to the chatbot, right? Whether it's actually the patient's previous history or the clinical examination, which might change the diagnosis. So I think, and the diagnostic assistant AI, those are not new gen AI. Those are what I call boring, narrow AI. That was developed pre-2022, but guess what? Those are really good AI, because those are the one where you're highly reproducible, tested in clinical trial. We know what the cost benefit is, and now for us and the way that we found that it really worked is not just deploying it by software as a standalone. We're now working with the hardware manufacturer, so that their hardware, their video input, their CT, the MRI, works just as well as the way that when we test it in a generalized model. So that when, the way that we want to shape the ecosystem is that now, in the future, when someone buys, let's say, a colposcopy or gastroscope, the AI comes with it as a standard package, rather than something that people have to add on, have to learn. So I think this is also part of the scalability pathway that I think we are now just about to embark on. And to the question is, we've done this, I wouldn't say successfully, right? I think we've done quite okay within China, and we are in the process of expanding this, especially to the global south and to Southeast Asia. But the way that we are doing it, we're also working with local partners. We need to understand the local data architecture, the local pathway, and I have to say, we probably have to do some bridging trials to make sure that the AI that we have developed can be applied locally to the local pathology, to the local practices, right? So I think there's still a progress of transitioning, but I think this path will be much faster than smaller companies trying to develop this as a standalone, because we've also seen it within China. These small companies, what they would happen to do, they can raise funds, but then they usually die out after a few years, because they couldn't have a business model to sustain it. And this is what I am seeing right now. But at the end of the day, it's about the choices that you make on how you actually build a scalable platform, because this is the only way that you can ensure that we can continue to reinvest in the AI to make it better, to make it safer.
We have 1 minute left. Let's have a last question, please.
Hi, I'm Samin Mirza. I'm from Access Health. We're a nonprofit policy think tank. We've been doing some research on responsible health AI policies and their implementation, and the ethical use of AI as a course from the WHO was something that we've gone through and really enjoyed. but I wanted to understand how far are these types of courses being implemented in the curriculums of different medical professionals, whether it's informaticists or doctors, nurses, community health workers. How far are these being implemented? And if possible, when it comes to procurement, how far are people being trained on evaluating an AI's safety and responsible use before adopting it?
I think this question to Derek. Right?
Yeah, thanks so much. Thanks so much, A and B. Yeah, thank you so much. We appreciate the feedback on the courses that are being produced from WHO's perspective. Even though we say WHO courses, these courses are informed by the global ecosystem. There's a number of actors that have informed the production of these courses. Our flagship course, the Digital Health Planning National Systems, has received feedback from a number of players, both from development agencies, the UN family, academia, and also the ministries of health, the end users themselves. The course on ethics and governance on AI, which was the first in the series of the AI courses, received input from the actual handbook, the ethics and governance on AI. Is deployed on the Open WHO Academy, but we have been transitioning these courses into the WHO Academy itself. And so do take a chance to look at the course offerings at the WHO Academy. There'll be more and more digital health courses being deployed there. We have basically used the competency-based approach to enable countries to tailor these courses to their local setting. And that's really the direction that we like to take, whereby WHO defines the knowledge, skills, and attitudes of different actors so that the countries are able to tailor the courses to their needs. So Malawi is a good example. They have used the WHO standard Digital Health Planning National Systems course deployed on the WHO Academy, and they are now localizing it to their local context using their local learning management system. Now, to do that efficiently, we have already begun talking to them about the competency framework so that any tailoring is done based upon competencies, and that this should also be informed in the National Digital Health Strategy. And so our mandate is really a competence-based approach. Any course that we design, whenever you see a course coming from WHO, basically it means that the space that course is filling is vacant. We would like the ecosystem to build courses so that our role would be on the normative side, on the knowledge, skills, and attitudes description. And so that's the first part of the question that I'd like to take, and I'll encourage the panel members to address the second part of the question. Thanks so much.
Just quickly, in my experience, most regulators do not require an IT or bioethics component. As Bill pointed out, the U.S. regulator does. And I wanted to sort of address that first education question. We talk about the use of technology and AI in 4 different ways in health professional schools. One is to use AI in the actual teaching, whether it's through the case studies or through interleaving or, adaptive learning. The second is teaching the health worker how to use AI and technology in their practice, how to integrate it in their practice so it supports them and they don't, hand all decisions over to it. And the third is using AI to manage the health professional school. Health professional schools are very complex organizations, and you can also be very expensive, so you can operate them a lot more efficiently using technology and AI. And then the fourth function is to train health AI professionals, because as Bill pointed out, we really need people who understand both the technology side and the health side.
Let's conclude our session with another round of applause of all the speakers and also all the participants join this session. Thank you very much.